Hello all, welcome back. So the exam dates of EMREE has been announced and it's around the corner in a month and it will continue until March. So whoever is preparing, all the best for you. We shall start discussing questions also in the coming days. Today it's about pediatrics, the things I've compiled during my preparation. So this is the breakdown of syllabus from the general pediatrics. There is infections, the neonatology, immunization development. They're all important. Just go through the syllabus for once, and so you know what to expect and where to be focusing on your reading while preparing. So immunization development, failure to thrive, neonatology, endocrinology, the newborn screening, uh, metabolic disorders, then other things as well. So just go through the syllabus and we'll get started. So immunization. So when you know immunization, you have to know the schedule, like the time when it is given at birth, 2 months, 4 months, 6 months, 12 months, etc. You have to know what kind of vaccines you're giving. You have to know the route and major contraindications. So these are the things that you must know. So at birth you're giving BCG and hepatitis B. 2 months you're giving hexavalent vaccine, which includes DPT, or you can call it acellular pertussis, that is AP, DTAP. D for diphtheria, tetanus toxoid, and acellular pertussis. That's what you have in AP. Then HIB means Haemophilus influenza type B. IPV means injectable polio vaccine. And you have hepatitis B. Then you have PCV, which is pneumococcal conjugate vaccine, and rotavirus, which is an oral vaccine. So oral vaccine you have OPV, which is oral polio vaccine, and you have rotavirus. These are the two oral vaccines that you're having. Okay. Then again at 4 months you have the same things, hexavalent. You have PCV. So you have hexavalent, you have PCV, and you have rota. The same thing at 2 months. At 6 months also, pentavalent is there. So you're not having an IPV at 6 months. IPV you're only having 2 doses. So you're having pentavalent, which excludes IPV. So you have DPT, hib and hepatitis B. Then you have OPV. Okay, starting at 6 months. Then PCV, third dose, rotavirus, third dose. At 12 months, you have MMR, which is measles, mumps, and rubella, and chickenpox. Then at 18 months, you have um, from the pentavalent, what is there in pentavalent? DPT, Hib, and hepatitis B. So you don't have hepatitis B. First, you excluded IPV. At 12 months, you are not having any pentavalent, hexavalent, or anything. At 18 months, you are again having that pentavalent like thing, except for hepatitis B. So you're having DPT, Hib, then you are having IPV, then you're having OPV, okay, then you're having MMR also. MMR after the 12 months, at 16 months, you're giving the second dose. Then at 5 to 6 years, 13 to 14 years, and 15 to 18 years, you're repeating the DPT. Sorry, at 5 to 6 years, you're repeating DPT, and 15 years, you're giving Tdap. So almost like DPT itself, but you only need an adult dose of diphtheria. That's why a smaller D, and acellular pertussis. At 13 to 14 years is when you're giving your HPV vaccine. At 5 to 6 years, you again have IPV and OPV and chickenpox. Varicella, you're having second dose at 5 to 6 years after your 1 year dose. 15 to 18 months, you again have a meningococcal vaccine. You'll again see some more. So how do you remember all this information? So you have to know the time which they're given and what are the vaccines you're giving. So at birth, two vaccines, BCG and hepatitis B. Now we have 2 months, 4 months, and 6 months. Now for 4 months, that is second month and 4 month, you have the same vaccines: hexavalent, PCV13, and rota. Hexavalent again is having 6 vaccines, which includes DPT, diphtheria, pertussis, tetanus toxoid, and uh, Haemophilus influenza type B, hepatitis B, and IPV, and PCV13 and rota. 6 months also almost similar. Instead of IPV, you are having OPV. Okay, so you are taking out IPV, so hexavalent becomes pentavalent, which includes DPT, Hib, and hepatitis B, and OPV, PCV13, and rota, as usual in second and 4 months. Okay, so that is 2 for 6 months. Now the next schedule comes at 12 months. 12 months you are giving 2 vaccines, which are MMR and varicella. Only 2 vaccines. So MMR and varicella. Now when is the schedule? Next schedule at 18 months, next at 5 to 6 years. So you can put this MMR into 18 months, varicella into 5 years. Okay, so first dose of MMR comes at 12 months, second dose comes at 18 months. Okay, first dose of varicella comes at 12 months, second dose comes at 5 years. Okay, so that is for the 12 months. Now you can just remember that OPV is given first at 6 months, then 18 months, then at 5 years. So 18 months, what all you are having? You are having the second dose of MMR, then you are having DPT, IPV, and OPV. 5 years also, you are having the second dose of varicella, like mentioned, and you have the same things that you're giving at 18 months: DPT, IPV, and OPV. So this is, I think, in short, how you can remember. At birth and at 2 years, you at 1 year, you're having 2 vaccines at birth: BCG, hepatitis B; at 1 year, that is MMR and varicella. MMR you're having the second dose at 18 months, varicella you're having the second dose at 5 years. 2 for 6 months, it is mainly DPT, Hib, hepatitis B, IPV given 2 4 months. 6 months you're giving OPV instead. PCV 13 and rota given in 2 4 6 months. Okay, then 18 months you're having and 5 years you're having DPT, IPV, and OPV. MMR in 18 months, varicella in 5 years. Okay, now these are certain contraindications and the route of vaccine. So oral vaccines are oral polio vaccine and rotavirus vaccine. Okay, this oral polio vaccine is a live attenuated vaccine. Intramuscular is almost other things. You just have to know which are oral, which are intradermal, and which are subcutaneous. All others are intramuscular. Subcutaneous is measles and yellow fever. Intradermal is only one vaccine, which is given at birth at the left deltoid. Why is it given at left deltoid? For universal identification, so that you have a scar over there and you can see if the patient has been vaccinated at birth. So that is your intradermal BCG. Oral is OPV and rota. Subcutaneous is measles and yellow fever. All others like your pentavalent, or you can remember it like your hexavalent, which includes your DPT, hepatitis B, IPV, Hib, and PCV. They are also intramuscular. Okay. OPV and BCG are absolutely contraindicated in HIV patients. OPV is a live attenuated vaccine, and BCG, they are absolutely contraindicated in HIV patients. Preterms, they get vaccine at actual age, not their corrected age. So preterm individual who, like for example, a baby who is now 6 months, okay, 6 months of her chronological age after birth. Now she is 6 months, but she was preterm, she was born at 8 months. You don't have to correct her age when you are looking for the vaccine schedule. You can give her every vaccine based on her actual age. But if it's a preterm and you're having a developmental delay, you have to correct her age to her actual corrected age, and then look for any developmental delay. So development, you see there, so development, if it's developmental delay, you see for their corrected age. Okay, age which is corrected, you write a C, which means you are looking for the corrected age and not the actual age. But for vaccine, you look at the actual age. Okay, if a pregnant taking biological agents like anti-TNF in the second trimester, then live vaccines for her baby should be delayed for 6 months. If she took it in the third trimester, then live vaccines should be delayed for 12 months. Okay, there's some points. Okay, if the pregnant has been taking biological agents in the second trimester, delay for 6 months. If taking third trimester, only the live vaccines. Okay, live vaccines should be delayed for 12 months. Now, if a baby is having complement deficiency, give all vaccines, especially meningococcal, because they are prone to infections. Chronic granulomatous disease, again a kind of immunodeficiency, don't give bacterial live vaccines, which is BCG, typhoid. Now, there are some complications, non-complications of certain vaccines. Rotavirus is associated with intussusception, flu vaccine with GBS. Egg allergy is an absolute contraindication to yellow fever vaccine, a relative contraindication to influenza vaccine maybe. Neomycin gelatin allergy is a contraindication to MMR and varicella vaccine. So have these concepts clear, because some questions may come from these areas. Now this is about catch-up vaccine. Um, so if you haven't given DPT, what is the minimum age for dose 1? It is 6 weeks. In the schedule we are actually starting at 2 months. So dose 1 to dose 2, the actual gap should be 4 weeks. Okay, so we are actually giving it, this is minimum interval between the doses. The actual schedule is actually 2 months apart, 2, 4, 6 months. Okay. Yeah, so this is just a table. I think you can go through this. IPV you're giving minimum at 6 weeks, but you're actually starting at 2 months. Hepatitis B you're giving at birth. MMR you're giving at 12 months. Varicella again at 12 months. Hib you're starting at 2 months. Pneumococcal you're starting at 2 months. Now, what are the contraindications to certain vaccines? Severe allergy to a vaccine component on the prior dose is an absolute contraindication. Like life-threatening allergies to eggs. They receive MMR and influenza under observation, but they cannot receive yellow fever vaccine. Exercise caution in administering yellow fever to those with egg allergy. Encephalopathy within 7 days prior 7 days of prior pertussis vaccine. So pertussis again is known for seizure, causing seizure or encephalopathy. So encephalopathy within 7 days of prior DPT or pertussis vaccine is a contraindication. Maybe you can give a cellular pertussis that is having lesser risk than the whole cell pertussis. Personal history of intussusception is a contraindication of rotavirus. Like we mentioned, rotavirus may predispose to intussusception. Avoid live vaccines like rotavirus, OPV, varicella, MMR, intranasal influenza, yellow fever in immunocompromised and pregnant patients. HIV can receive MMR and varicella. In HIV, BCG and OPV are absolute contraindications. Weight less than 2 kg for hepatitis B vaccine in newborns. You can just delay that. Otherwise, you look at the actual age and then give it. Now, these are the contraindications. What are the precautions? Moderate to severe illness with or without fever. Prior reactions to pertussis vaccine, which is not an encephalopathy or seizure, but other things like fever, a shock-like state, persistent crying for more than 3 hours within the 48 hours of vaccine, or seizure within 3 days of vaccination. History of receiving IVIG in the past year. So these are all precautions. Not contraindications, low-grade fever, you can give the vaccine. Current antibiotic therapy, not a contraindication. Prematurity, all vaccines given based on the chronological age, even if the baby is premature. Okay, so these are certain things regarding vaccination. Let's come to development. Development, you have to know in and out of development. You have to know the domains. You have to know when you call it a global development delay and when do you actually call it a delay. What are the milestones? You have to know that. So before going to development, what are some parameters of average growth at birth? So birth weight, usually you can call it 2.5 to around 3.5 normal, or up to 4 kg. Okay, you gain 20 to 30 gram per day. Mm? Then you become 2 times the birth weight by around 4 to 5 months, 3 times the birth weight by around 1 year, 4 times the birth weight by around 2 years. Actually, there is a 10% of birth weight that is being lost in the first 7 days, and this is actually normal. So, in some question, they can come up like a 3 kg baby who is at after 5 days. Mother complains that when you maybe they're getting discharged and then they weigh the baby, and the baby now only weighs maybe 2.8 kg, and the mother is concerned. Maybe he was 3 kg when he or she was born. Now why is they less in weight? So this can happen because they can lose up to 10% of their birth weight. So 3 kg can lose around 300 grams of weight, which is absolutely normal. And now they pick up the weight after the 7 days. They regain the weight by 10 to 14 days of age. Now length, it is 50 centimeter, and these all can differ based on the familial pattern also, but this is average things. So they grow 25 centimeter in the first year, 12 centimeter in the second year, 8 centimeter in the third year, then 4 to 7 centimeter per year until puberty. They are half their adult age at 2 years. Okay, until 2 years you actually measure the supine length, then you measure the standing height. Head circumference at birth 35 centimeter. They grow, they increase 2 centimeter per month for the first 3 months, 1 centimeter per month for the 3 to 6 months, and 0.5 centimeter per month at 6 to 12 months. You measure around the occipital, parietal, and frontal prominences to obtain the greater circumference, and that is what you're mentioning as the head circumference. And always when you're using a tape, make sure that you're using the overlapping method to get the correct measurement. These are some reflexes. You have to know when they usually disappear. So motor reflex is when when the infant is placed semi-upright with the head supported. There is a sudden withdrawal of supported head with immediate return of support. What they do, they reflexively abduct and extend the arm, opening of the hands followed by flexion and adduction of the arms. This is the Moro reflex. Now usually disappears by 4 to 6 months. This can come in question. The time of disappearance is what you need to know. They'll tell the name of the reflex. You may not need to know the complete maneuver and the reflex response. You have to know the reflex and the age of disappearance. So more of 4 to 6 months. Gallant is ventral suspension, when the infant is held in ventral suspension and on one side of back is stopped. Along the paravertebral line, the pelvis will move in the direction of stimulated side. It disappears earlier in 2 to 3 months. Grasp is when you are placing your fingers, they're trying to grasp your fingers, and that disappears by 3 to 4 months. ATNR means asymmetric tonic neck reflex. So when you turn the infant's head to one side, they extend the ipsilateral arm and leg and flexion of the contralateral arm and leg. That disappears 4 to 6 months. Now placing dorsal surface of infant's foot placed touching edge of table, they resemble the walking like thing. Okay, rooting, again rooting reflex is important. They infant when you are stimulating near the mouth, they turn the head and open mouth to suck on the same side the cheek was struck. and that disappears 2 to 3 months. Parachute reflex is when you tilt the infant to side while in sitting position. There is ipsilateral arm extension. They present by 6 to 8 months and they do not disappear. So parachute reflex is not something that will disappear. Moro reflex disappears by 4 to 6 months. Grasp reflex by 3 to 4 months. ATNR by 4 to 6 months again. Rooting by 2 to 3 months. You have to know some of that. Okay. Now, coming to development, when do you say there is a significant delay? Significant delay is when there is 2 standard deviation below the mean with standardized test in at least 2 developmental domains. There are 4 domains: gross motor, fine motor, speech, and social, mainly 4 domains. Or you can have cognitive activities of daily living in a child less than 5 years. So developmental red flag signs: gross motor, not working at 18 months. Actually, by 1 year, they would be able to walk on by themselves, or maybe 15 years they'll be able to uh, walk by themselves. Even at 18 months, if they're not able to walk, or they are rolling too early at less than 3 months. If there is a hand preference less than 18 months, hand preference means usually in children, if you're giving a toy to them, they may not always pick up with the right hand or left hand. There is no dominance of hand. It is usually an observant phenomenon. Maybe they learn, they adapt, and it's usually a learned skill set which comes later. But if there is a rigid hand preference, whether there is a dominant hand, they usually, if they are picking up with the right hand or the left hand, that means maybe there is something wrong. Okay. Okay, so the hand preference is one thing. Speech less than 10 words at 18 months. Hmm? Usually in 2 years there is a 50-word vocabulary. In 1 year they can say some words. So if at 18 months they cannot say 10 words, they are red flags. Social, not smiling at 3 months and not pointing at 15 to 18 months. These are all red flags. What are the investigations that you will usually do? Vision and hearing test. You have to see if there is something wrong with their vision, wrong with their hearing, or maybe that is delaying them. EEG if there is a suspicion of seizure. Chromosomal microarray karyotype and fragile X DNA testing. Brain MRI if abnormal neuro examination. It is not that you have to do all these tests, but according to the history and physical examination, you can think of doing these tests like metabolic screening, glucose electrolytes, lactate ammonia, liver function, pyruvate, albumin, etc. And lead levels, CBC, blood gas, urea, creatinine, and OTPT, all those things. Now I'll come to development. So newborn, they have the primitive reflexes, they have Moro, they have asymmetrical tonic neck reflex, they have Babinski, all those things. And there is grasp reflex, there is rooting sucking reflex, and they fix and follow a slow horizontal arc. And usually there is a bonding between the parent and child. Now, also for development, this psychological stimulus is very, very important. So, if there is a development delay, you also have to look into that direction if there is something lacking between the parent and the child. Okay, are they getting enough psychological cues from their environment? 2 months, they briefly raise his head when 45-degree when prone. I have highlighted the very important developmental milestones in the following slides. That is why I'm just showing this slide. So 2 months again, there is cooing, hands open half of the time. They turn to voice. They prefer familiar caregiver. And there is social smile. So smile comes at 2 months, but when they laugh at around 4 months. Now at 4 months they roll from prone to supine, but supine to prone is a bit later at around 6 months. 4 months again there is palmar grasp. They are laughing. Okay, there is purposeful sensory exploration of objects, hands, eyes, mouth. They explore the parent's face. Okay, at 6 months there is a tripod cyst that is sitting with support. They transfer the object from hand to hand. They babble. Okay, and there is stranger anxiety. This is another important and favorite question. They express emotion, happy, sad, and mad. At 9 months, they sit well without support. 6 months, sit with support. 9 months, sit without support. And they crawl, okay, and they pull to stand. There is an immature or inferior pincer grasp. They can say mama, dada, they can show bye bye, and they can play peekaboo, and there is separation anxiety. This is another important one. Now, 12 months, they can walk a few steps. There is mature pincer grasp, and there is one word besides mama, dada, and they respond to their own name. They follow one step command with gesture, and they uses the objects functionally. They know the cause and effect. They point at wanted items. So that is pointing. Now again the same thing in a different words maybe. These are taken from different books. So again 1 month turn head side to side, hands fisted. They cry. They startle to loud noise. They calm when comforted. 2 months they raise head when prone. They hold erect when upright. They pull at clothes. They can coo. Okay, they smile responsibly. There is social smile. They comes down to familiar voice. Okay, 4 months. They can lift head and chest when prone. Okay, they can roll prone to supine. Okay, and they reaches for midline objects. They turn head towards the sounds and they laugh responsively. 6 months, tripod sitting, ulnar or raking grasp, transferring objects from hand to hand, bring objects also to mouth, and they babble, and there is stranger anxiety. 9 months, they sit without support, pulls to stand. There is a mature pincer grasp. There is mama dada, one word, and response to a no. They can play peekaboo. 12 months, they get into sitting position without help, they stand without support, they walk while holding on. There is mature pincer grasp. There is balls with throw. Sometimes these come in question. They releases a ball with throw. Then there is two words. They follow one step command. They use facial expressions, sounds, and actions to make their needs known. They respond to own name, and separation anxiety begins. Now, 15 months, 18 months, 24, 3 year, 4 year, 5 year. You have to know these also. So at 12 months, they were just walking with support. They may be, standing without support maybe, but walking with support. Now at 15 months, they can actually walk without support and they crawl up the stairs. At 9 months itself, they crawl on the ground. 15 months, they crawl up the stairs. They can stack two blocks. They can use a spoon. This is also important, sometimes come in question. They can say 4 to 5 words. They follow one step command without gesture. They look for moved hidden objects if they saw it being moved. Then point at interesting items to show to parent. 18 months, they can run. Okay, they can make a tower of 4 blocks. They can scribble. Then there is 10 to 25 words vocabulary. They know 3 body parts. Okay, they can symbolic play with doll or bear. There is parallel play. At 24 months, they jump on 2 feet. So there is jumping. Tower of 6 cubes, handedness established. So they either use a right hand for major things or left hand for major things. Early handedness is a red flag sign, like we told. 2 to 3 words, they know I, me, you. Their speech is 50% intelligible. They understand 2-step commands. Okay, they can solve problems. Now these all needs also, like I told, psychological stimulus. Like if there is a caretaker who is playing with the child, who is stimulating the child to let use their own, the thinking, problem solving skills, it can do. Otherwise they might not do. So it's not necessary that every child at 2 years would do every single thing in that. And their testing limit, so they start to show tantrums. It goes on until around 5 years. 3 years, it's ride a tricycle. So 3 for tricycle. They climb up 1 foot per step like an adult, but they cannot climb down 1 foot per step. They use both their feet on each step. They're mostly toilet trained by 3 years. They can undress themselves and they can draw a circle. Okay. Crows is actually at 4 years. Uh, then three-step commands, 3 words, 3 to 4 word phrases. They can ask questions with why. They have 200-word vocabulary with 75% intelligible. They can identify shapes and count to 3. Now these all depends. If they've been trained to count to 10 or 50, they can. Cooperative play, they can also do role play or pretending play. 4 years, they can hop on 1 foot and climb down 1 foot per step. And they can use scissors, they can button their clothes, their speech is 100% intelligible, they use this past tense and they can tell a story. They identify 4 colors and counts to 4 and has a preferred friend. 5 years, they can skip, they can ride a bicycle. Okay, they can print name, ties shoelaces, there is a fluent speech. They also know the future tense. They count to 10 accurately, recite ABCs, and has group of friends. Again, same thing. 15 months. I'm showing this again and again because this is very, very important. Walks without support, crawl upstairs, picks up and eats finger foods. They can scribble. They have 4 to 5 words vocabulary. They point to their needs and wants and look to see how others react. Like after falling, if others are, uh, anxious or afraid, they'll also start crying. 18 months, they run. They walk towards pulling toys or carrying objects. Tower of 3 cubes, you can again scribble, eat with a spoon. Eat with a spoon and all, they can maybe do at 15 months. That also comes with a little bit of training. 10 words follow simple commands. They show affection towards others and points to show interest in something. 24 months, they climb up and down stairs with 2 feet per step. They run and kicks ball. They can undress themselves. They know IVU. Their speech is 50% intelligible. They understand a 2-step command. There is parallel play and they help to dress. 3 years mainly rides tricycle. They can climb up the stairs 1 foot per step. That means like an adult, but they come down with 2 feet per step. Okay, they can draw a circle. They can dress and undress, and they can combine 3 or more words into a sentence. They recognize colors, plurals, and their speech is 75% intelligible. And it is at 3 years they know their age and sex, and she has some of the time plays make believe games. 4 years hops on 1 foot, copies. They can draw a cross. They use scissors and button clothes. Speech is 100% intelligible. And there is cooperative play. They are fully mostly toilet trained, maybe at 3 years itself. 5 years they skip, they ride a bicycle and they can copy a square first, and then usually at 6 years they can copy a triangle. Then there is fluent speech, their future tense, they can retell the sequence of a story, they cooperate with adults' requests most of the time, separates easily from the caregiver. So again, I have compiled the very important things into the coming up slides. 1 month alert to sound, and they follow the objects to midline. Okay, they know the familiar voices like their own parents' voice. Okay, 2 months they start going. They know their parents. They can follow past midline, and there is partial head support and there is social smile. Okay, they're usually happy. Okay, there is cooing, there is social smile. Okay, now at 4 months they start to laugh and they roll from prone to supine. They can sit with support. They bring hands to the midline and reaches for objects, and there is full head support. Usually from 4 months, developmental milestone that's been the question is laughing. 6 months, there is stranger anxiety. Stranger anxiety and separation anxiety is different. Stranger anxiety means if they are seeing somebody who is not their parents or their close caregivers, like their grandparents, like the ones they usually see, the familiar face, they cry. If they see someone outside there, they cry. That's stranger anxiety. What is separation anxiety? If they are taken away from their parents, they start crying, or if they don't see their parents for a while, they get anxious. So that is separation anxiety. It comes around at 1 year. 6 months, what we have is stranger anxiety. Now at 4 months, they have rolled from prone to supine. Now they can roll from supine to prone, and they can babble and they can sit without support. And they transfer objects, or there is mouthing. At 9 months, they can stand with support. They can say mama dada, they can play peekaboo, they can respond to a no, and there is immature pincer grasp. Okay, and they also say bye bye. At 12 months, there is separation anxiety. They can walk without support, and actually, they can walk by holding objects. They can stand without support, and they know few words. They have a one-step command. They can follow a one-step command. There is mature pincer grasp. At 15 months, they can walk backward. 18 months, they run. 3 years jump. 4 year hopping on one foot. 5 years they skip. 6 years balance on each foot for 6 seconds. So these are certain things. Again, what I want you to remember. 15 months, they can walk. 18 months, they can run. 15 months, they know how to use a spoon or maybe a fork. At 15 months, they can make a block of 2 blocks. 18 months, 4 blocks. 24 months, 6 blocks. At 2 years, they know I, me, you. They know a two-word sentence. But they don't know age and sex until yet in 2 years. They know it by their 3 years. And they know a three-word sentence. They can draw a circle. They can go upstairs with like an adult. That is 1 feet on one step. They can ride a tricycle. At 4 years, they're storytelling. They can come down the stairs like an adult. They can draw a cross. At 5 years, they can ride a bicycle. They can skip. They can draw a square. And at 6 years, they can draw a triangle. Okay. So just added this, not related to development, but these are some medications that can cross into the breast milk. Antimetabolites, bromocriptine, chloramphenicol, high-dose diazepam, ergots called metronidazole, tetracycline, lithium, and cyclophosphamide. Tetracycline can cause teeth discoloration. You can remember it like tetracycline or teeth discoloration. Lithium, when passed into the baby in utero, I'm not saying through breast milk, in utero. So this is beyond, a bit, before they are being born. In utero exposure of lithium. This is again another important thing. In utero exposure of lithium leads to Epstein anomaly. What is Epstein anomaly? It's atrialization of ventricle. Atrialization of ventricle means the atrioventricular valve, like the tricuspid and the mitral. Usually the tricuspid, it will be fixed a little bit down. So it is more of atria than the ventricle. So it will be a very little ventricle and a big atria. So that is called atrialization of ventricle. That is the Epstein anomaly, usually seen with in utero exposure of lithium. Cyclophosphamide, even in adults, can cause hemorrhagic cystitis. Okay, others can also have some problems. So failure to thrive. What is failure to thrive? That the baby is failing to thrive. It's in the term. They are not able to gain weight. They may be losing weight, and they are not able to feed. So it's very likely that the baby is going into some kind of a problem. So what are the clinical signs? Subcutaneous fat loss, muscle atrophy, there is alopecia, lethargy, they're lagging behind normal kids, kwashiorkor, which means there is malnutrition with edema, there are recurrent infections and dermatitis. Now when you talk about failure to thrive or maybe the height of the baby, You also have to know something called mid-parental height. That is the target height that the baby is supposed to attain. Okay, when they reach their maximal height. So that means it is for boys it is father's height plus mother's height plus 13 whole divided by 2. For girls it is father's height plus mother's height minus 13 whole divided by 2. So that is mid-parental height. Now why is it important? So if suppose we are given a graph. Now there are so many centiles in the graph being marked like this, okay. Now suppose the kid that we are being told, so this is the third centile, this is maybe the 50th centile, okay. So these are like different centiles. Now we know it is very uh, usually pathological when it is below third centile. Okay, even height or weight below third centile means there is some kind of malnutrition or something wrong. Now suppose the baby is not having a 50th, or the child is not having a 50th centile. So suppose if this is the 50th centile, and the baby's or the child's graph is looking something like this. So it is here, here, here. So it is not below third centile, but it's not normal also. It's not up to the mark also. So you just calculate the mid-parental height. Suppose the father's height is 160 centimeter and the mother's height is 150 centimeter and it is a boy child. Okay, so you have different charts also for boys and girls. So suppose if it is a boy child, so it's 160 plus 150 plus 13 whole divided by 2. That makes it 323 by 2, right? 323 divided by 2. How much that becomes? That becomes 161.5. Okay. So if 161.5 is coming here, suppose it is coming here. Okay. Suppose here. So that means the child is actually short, but they are growing up in a way that they are likely to attain their mid-parental height. If they grow in this same pattern, they might attain that mid-parental height. That is what is mid-parental height is for. To see if they are growing up to their genetic potential, maybe. Okay. So what is failure to thrive? There is weight less than third percentile. They fall across two major percentile curves, and there is less than 80% of expected weight for their height as well as their age. So there is something called weight for age and weight for height. Okay, because someone who is under height, maybe due to familial, they may be underweight also. So there is some expected weight for their height and some expected weight for their age. So if they're less than expected, 80% of expected for weight for height and age, it is all failure to thrive. You can look for things that are wrong with them like CBC, blood smear, electrolytes, T4, TSH. You can do a bone age X-ray again to look if they are growing up to their full potential. Maybe their bone age is not lacking. Okay, so you also have to look for the familial height and all, mid-parental height and all. You can look for chromosome and the karyotype. Like in, for example, Turner, you have short stature. Chronic illnesses like in you can look for chest X-ray, rule out cystic fibrosis by doing a sweat chloride test. Cardiac, you can again evaluate by chest X-ray, ECG and echo. GI, look for celiac screening, inflammatory markers and malabsorption. Renal, look for urine analysis, and liver enzymes and albumin. And there are failure to thrive different patterns. One, there is decreased weight, normal height, and normal head circumference. So only weight is affected. So that usually indicates a caloric insufficiency, and there is decreased intake or a hypermetabolic state, like maybe hyperthyroid state, or increased loss. Now, if both height and weight are decreased, but head circumference is normal, so there may be a structural dystrophy or endocrine disorder, or a constitutional growth delay where the born age is also less, or a familial short stature, which means the born age is uh, same as the chronological age. They are just short. They are just short, so that they are also less in weight. Okay, so that is why you get the mid-parental height. Decreased weight, decreased height, and decreased circumference. That means it's a intrauterine insult or a genetic abnormality. So you screen up for other things. Now, what is the best indicator for acute malnutrition? It is weight for height, which is less than 5th percentile. Now, what is the best indicator for under and overweight children? That is BMI. BMI means weight in kg divided by height in meter square. Height in meter square. Height square. So that is BMI. What is the most common cause of failure to thrive? It's psychosocial deprivation in old age groups. Okay, psychosocial deprivation. So for growing, you also need psychological stimulus. For development, you need psychological stimulus. Okay, so remember, acute malnutrition is weight by height. Now, what is the next step of cases of underfeeding? You have to report to Child Protective Services. Now, there are different classifications for malnutrition. So Waterloo classification is for classifying protein energy malnutrition in child based on wasting. Wasting is weight for height, okay, based on the weight for height. And stunting. Stunting means height for age, okay. So Waterloo classification, that there is normal, mild, or grade 1 protein energy malnutrition, grade 2 and grade 3. Now, based on stunting and wasting. Wasting is weight for height, and stunting is height for age. Yeah, so there is weight and there is height. Okay, and there are three things. There is weight for age. Okay, there is height for age. Then there is weight for height. Weight for height. Weight divided by height. Okay. So this weight for height, if it is very low, we call it wasting. Okay, wasting. Now height for age, if it's very low, we call it stunting. Stunting. Now weight for age, if it is very low, we call it underweight. Underweight. Okay, underweight. So wasting is different, underweight is different. Wasting is when weight for height is less, underweight is when weight for age is affected. So again, more than 90%, they have different values there. You just have to know Waterloo classification based on protein energy malnutrition, based on wasting and stunting. Wellcome classification based on whether edema is present and absent. So if there is, and again looking at the weight for age. Here you're looking at weight for age. Waterloo is looking at weight for height and height for age. Wellcome is looking for weight for age. So if it is 80 to 60% of standard or less than 60% of standard. So if there is some amount of malnutrition, that is weight for age is less, 80 to only 80 to 60%, along with edema, you call it kwashiorkor. If there is no edema but less age, you call it ponderal retardation. If there is very less weight, that is less than 60%, with edema, you call it marasmic kwashiorkor. Okay, if there is edema, it's always kwashiorkor. If its weight is very less, you call it marasmic kwashiorkor, otherwise you call it kwashiorkor. Now, if the edema is also absent and the weight is also very less, and the baby is like paper thin, it's called pencil thin, it's called marasmus. Okay. Now, there is some other classification also, which is Gomez classifications based on weight for age again. In the system, the normal reference child is 50th centile. So weight for age, you get it into a percentage and you look if it's more than 90%, 75 to 90%. Based on that, you grade it into 1, 2, 3. Again, the stages of malnutrition. Okay, now just some basic facts. Cow milk contains more protein and iron, but they are less bioavailable to human than from human milk. But human milk contains more carbohydrate and more antibodies. They both contain the same amount of fat, but human milk has more essential fatty acid and they contain the same calories. Usually this comes in question, what is more in cow milk, what is more in breast milk. So calories and fats, same. Protein and iron, more in cow milk but more bioavailable to human in human milk. Human will contain more carbohydrate, or think it like it is more sweeter and it is more strong, like you have more antibodies. Okay. And infants fed exclusively on got milk, they are at risk of developing megaloblastic anemia unless they are fortified with folic acid or they are supplemented with folic acid. So one question has come, the children who are exclusively fed with got milk will need what supplement? It is folic acid. Goat's milk will contain 6 microgram per liter of folate. The breast milk and cow's milk will contain approximately 45 microgram to 50. Coming to neonatology, this is going to be a bit longer, so we'll continue with the rest of the class after stating a few points in neonatology. I just wanted to highlight the UPCAR score. UPCAR score means at you're looking at 1 minute and at 5 minutes. 1 minute or soon after birth and at 5 minutes. Now these means different things. At 1 minute, why do you look? To see if you need resuscitation or not. Resuscitation. Not resuscitation score. It is whether you need resuscitation. Okay. Whether you need resuscitation or not. Whether resuscitation or not. Now 5 minutes means their response to resuscitation, whether they have responded to resuscitation. That is what this means. Okay. Or you can say the 5 minutes one is like a mortality indicator. If they have not responded to the resuscitation and they have a very low score, that means mortality risk will be high. So it is 0 points, 1 point, and 2 points for different things. APGAR is like an acronym: A for appearance, B for pulse, G for grimace or reflex irritability, A for activity or the muscle tone, and R for respiration. So appearance, it is either completely cyanotic on both the extremities and all over the body, or only the extremities are cyanotic. If the extremities are cyanotic, it is 1 point. Or if it is fully pink body, it is 2 points. Now pulse, if there is no pulse or a floppy baby, it is 0 point. If it is less than 100, it's 1 point. More than 100, 2 points. Grimace, like fully flaccid floppy baby, it's 0 point. If there is minimal response, it's 1 point. If there is prompt response like sneezing or crying or pulling away when stimulated, it is 2 points. Activity, if there is no movement or flaccid floppy baby, it's 0 points. Flexed arms and legs, 1 point. If there is active motions, 2 points. Respiration, absent or no breathing, it's 0 points. Weak or slow irregular breathing, it's 1 point. Vigorous, like a strong cry, it's 2 points. So this is UPCAR score. There is something called a Ballard score also. You just have to know that this is like a You don't have to know all of this thing. This is like a neuromuscular maturity score in like a preterm individual, preterm child. Okay, just know the name of the score. It's Bellard score. So that's all. We'll continue with the rest of the session in the